I would like to start the second session. My name is Toshio Kitamura and Torsten.
Good morning, my name is Torsten Haferlach from Munich.
The first speaker?
Yes, the first speaker will be coming from Finland, and Oskar Brück. I met him first some weeks ago when I visited Helsinki for the first time in the group of Kimmo Porkar, and we are looking forward, Oskar, to your talk on genetic and clinical diagnosis based on bone marrow cell morphology, and both of our talks will also focus on the use of artificial intelligence in diagnostic and prognostication in leukemias. Oskar, go ahead.
Thank you, Torsten. First of all, thank you very much for the organizers for the invitation, and it's been a really lovely meeting so far, and very difficult to continue after Professor Bennett on this. So I will describe how AI can be used in analyzing bone marrow cell morphology. Here are my disclosures. And on the right side, you can see where I live and work. So the campus is next to the sea. It's really lovely, both in the summer and winter time. You can go skiing. So please, if you have any intentions to come and visit Finland, please contact me. Before discussing the imaging part, as the MDS Foundation is really based on collaborations, we would like to start with a very brief few slides on the Helsinki University Hospital Data Lake that I've been working on now 7 years. The idea is that when collecting clinical data for various different projects, it requires a lot of manual work, and nowadays we don't do that anymore. So about 7 years ago, with Professor Porkka in Helsinki, we set up the Helsinki Hematology Data Lake, which is a data secure environment where we get all the data from the EHR. It's basically downloaded every day, and we set up. We invested a lot of time and effort in setting up in an infrastructure where we can get curated data, meaning that we have very nice tables for diagnoses, treatments, lab data, basically anything that is typed in the EHR, we have that. And on the right side, you can see as examples that we have also developed text mining algorithms to parse, for example, pathology reports and have all the blast percentage, cytogenetics, molecular genetics, flow cytometry, and so on. How does that look for MDS? So we have about 1,000 patients with MDS, MDS-MPN spectra. And for each of those, we know the treatments, the molecular genetics, cytogenetics, and also, obviously, we can then replicate the WHO subgroups, look at their survival, and also the IPSSR and IPSSM scores. So please, if you have any kind of intentions to validate any clinical finding, it's very easy to do that in Helsinki nowadays. So then the actual topic, so the imaging part. So first, I'll give a very brief introduction to computer vision. Then describing a few imaging studies in MDS, and lastly, more on the algorithms that my lab is developing, and especially on cell classification. So computer vision starts from, you have a set of maybe pathology slides that you would like to analyze. You have digitized those with a microscope, with a digital scanner. It can be H&E slides, MGG stain slides, or even cell culture wells that you have digitized. And now you have a lot of data. What you do first is that you might need to pre-process them, so get rid of some technical artifacts. It can be that the images are not evenly illuminated, for example. You might want to, it's called image augmentation. You might want to process the images so that you generate synthetic data. And all of those can be, the purpose is to make better models. And the actual step that, when talking about image or computer vision, people maybe think about is the image analysis part. So if you have the images that you want to analyze, and you can do various tasks. It can be that you want to detect cells, segment cells, so you want to really delineate the cells based on their cell membrane. You want maybe to classify cells, or maybe just to segment the areas in the samples based on their colors and textures. And for each of these tasks, you have designated algorithms. And really on the kind of a theoretical part, when you look at the image, your brain thinks, okay, I see cells. The computer does not do that. The computer sees, it's called matrices, so it's tables, where in each pixel we have 3 values. One for the red color, one for the blue, and one for the green color. And when developing these algorithms, what you need to do, or the algorithms have been designed for that, what they do is that they read those pixels, so the pixel data, and the task is called feature extraction. So they transform those pixels in a representation that they can use to understand what is happening there, and then understand, okay, this cell is a blast, this cell is a non-blastic cell. In a way, it's very simple. So using this theory, so we analyzed a few years ago 236 MDS and 87 MDS-NPM patients, samples, and we extracted the features, so the visual representations of H&E stained slides. And how does that look like? On the right side, you can see each dot is one very small area of these images, and we can see that they cluster automatically based on their kind of what they represent. It can be that they represent hypercellular bone marrow, it can be they represent bone trabecularis stroma, red blood cells. So it's, they divide very clearly from one another based on how they look. And so this confirmed that, okay, we have been able to extract clinically or pathologically meaningful data, and next we can then develop models using those features to predict whether these MDS patients have, for example, mutations or karyotype changes. And we were surprised that we could develop very accurate models using just the H&E stained images. The top scores were for predicting the occurrence of TET2 mutation, ASXL1 mutation, and monosomy 7. But we were even more surprised that not only were we able to predict those, but the model probability, so how well the model could see or predict the occurrence of these mutations, correlated with the actual variant allele frequency of these genes. Or if we were predicting, for example, the number of mutations on a signaling pathway, the number of genes that were mutated also correlated with the probability of the model. The image in the middle doesn't look right, but next what we did was that we wanted to reanalyze those images using pixel level and cell level analysis. So the idea was that if we annotate each of the pixels if they represent hematopoietic cells, red blood cells, stroma, or lipid droplets. Or on the right side, you can see cells. So we identified individual cells, and we wanted to see whether these cells had dark nuclei, bright nuclei, whether the nuclei were round, what is the shape. So we used that data to understand then what the models were actually seeing when predicting, for example, for ASXL1 mutations. Now you don't see the result in the center, but basically we could see that these models kind of predicted, but they saw the same things for multiple different features. So for example, if the patient had a mutation ASXL1 or a deletion 5q, they kind of correlated quite well with one another. So similar features were related to the same to these alterations. I will very briefly describe another work that be submitting in the following weeks. So using the same data collection We also applied 7 panels of multiplex immunohistochemistry to stain for T cells, myeloid cells, and immune ligands, and used image analysis then to quantify these cells and their phenotype, and also look at how close these cells were from one another. We are then also combining the H&E features as well, and what we saw, well, based on the immune profiles, we can see 4 different clusters. I won't describe these more, but we could also see that the immune phenotype based on this image analysis were indicating also whether the patient had some specific chromosomal rearrangements or alterations in their genome. And one of the top findings was that patients with the trisomy 8, which were very often hypoplastic MDS, had numerous alterations or numerous their T cells were kind of activated, so had a lot of changes indicating immune activation. The first study by Professor Haferlach and Professor Gerstung, which my lab likes very much, and we've been discussing this multiple times. So here the colleagues have analyzed MDS and anemic patients and healthy patients and the MGG stained peripheral blood smears. What they did was they detected first white blood cells and red blood cells and designed very kind of a simple but very elegant models to extract the cell size and geometrical features of these cells. And the idea was that can the authors then predict whether the patient had a disease, so the disease was anemia or MDS, whether the patient had a mutation in the SF3B1 gene, and whether anemia was more iron deficiency or megaloblastic anemia. And the image here on the left side, basically what you see is that you have 7 white blood cell specific clusters on the left, and on the right 7 red blood cell clusters. And the letters indicates whether the, for example, for here, if the patient had a mutation in the SF3B1, this patient had more of the clusters 1 and 3 for the white blood cells and cluster 3 and 4 for the red blood cells. And what they indicate was that this patient with a mutation had more nuclear abnormalities in the neutrophils and haplopolypid neutrophils, as Professor Bennett just showed what it could be, and also that the red blood cells were larger and had elliptocytes. And this is kind of the thing that we should be doing, and really kind of explain the association between the morphology and these clinical and molecular alterations, to really kind of link these back, and that is not 2 different entities that is part of the diagnosis, but rather kind of understand how the pathology is linking the mutations and chromosomal alterations to the morphology. But maybe the most hottest topic in image analysis has been to classify cells and detect cells, and there are numerous work. Probably here again the best is by Professor Haferlach's team, and so there are about maybe 5-6 different publications on this. How they differ is mostly on how many different cells are you able to detect from these MGG stained cytomorphological slides. The techniques are very often the same, so convolutional neural networks, which is kind of one of the states of the arts in image analysis, and maybe kind of the one weakness in all of this work is that they have not been really validated in external data sets, at least robustly. And we are also working on this a lot. We have been working now for 2-3 years, and it's very challenging. So probably pathologists will still have work for many years. But the thing that we are trying to do is that first we want to build a really, really large image data set. So we have digitized now for 3 years, almost 24/7, about 100,000 samples into images. We have bone marrow, peripheral blood. The colors, you don't need to, well, they indicate whether it's bone marrow, peripheral blood, whether they're pediatric or adult patients. And we also have, luckily, samples from about 10 different centers. So the idea is that we want to make models that are really robust for different patient groups and for different scanners and different clinical centers that actually could be used in clinical work. So we tried first, it's the same technique, so convolutional neural networks, and we got results that were, I would say, satisfactory, but not really excellent. This is called a confusion matrix. The rows indicates the true labels, and the columns indicates the predictions. And if the prediction would be excellent, you would see a dark diagonal with values close to 100%. And we can see that the values vary between 50 to 100%. As said, they're not excellent. But recently, looking very much on how people work in the solid tumor side, we've been developing models using so-called transformers. I won't go to the detail, but it's kind of the next technique. They are more computationally intensive, but we get much better results. And another technique is called self-supervised learning, which I will describe in the next slide. And together, they improve the results a lot. Looking, for example, at blasts, the improvement was 10%, and that's a huge improvement that would mean that we need to annotate about, let's say, 100,000 cells more to get this improvement. So very, very eager now on these results and working on validating now this on different data sets. So what is self-supervised learning? First, supervised learning is quite simple. You have images, you say this is a blast, this is a monocyte, this is a lymphocyte. You build a model, the model understands that. But it takes a lot of time. So we have 100,000 cells annotated, and it took maybe 1.5 years to do that. We did that multiple times because we were disputing over whether this is a blast or not. But we had millions or even billions of cells. So what we did is we combined cells from different scanners, centers, and sample types together and built first a model that understands how these cells vary from one another. And using these kind of representations, so what the models are seeing there, we build another model using the supervised learning. And this is kind of the really what made the results much better. Well, again, it doesn't look that nice, it's a bit cropped, but you can imagine that there is a 2D dimensional plot where the cells, based on these self-supervised learning representations, they form specific clusters based on what is their cell type, but not all. For example, these green ones indicate myelocytes, metamyelocytes, and neutrophils because they're more closer to one another. And really one of the cool things that we notice as well is here is a promyelocyte. So even we didn't teach this, but the self-supervised learning was able to kind of detect the cell inclusions, for example, error rows and such from these cells automatically. So we can really see that we have now features in this model. It's kind of a foundation model for us that we are building all our models upon after that, is that they detect the correct things to understand dysplasia and other things. So now we have been developing about 15 different models for different dysplastic subgroups, as Professor Bennett showed. We have for the megakaryocytes, erythroblasts, neutrophils, promyelocytes, whatever, and we have integrated this all in a clinical software, which is now being certified to be used in the clinic, probably still within this year. And we also analyze the whole slide. We look at the number of megakaryocytes, cellularity, and try to replicate as much as possible what the physician or the pathologist is doing. We had one trial on that, and we got really positive results. On the left side, you can see how the application was able to assess the cellularity of the sample and it's very much in line with what the physician reported. And on the right side, we predicted whether the patient had, how many megakaryocytes they had on the slide. And actually on the right side, so you see more variance there, but actually the application is doing that more objectively. So we have had 7 physicians evaluating these, and we can see that there's a lot of subjectivity depending on who is analyzing them based on the experience. So the take-home message is, well, maybe 2 key points. One is that image analysis is used much less in hematology than in solid tumors, and maybe that's something that we should think about, that are we doing too much genomics, that we are missing kind of the basic samples, so the cytomorphological samples, histopathological samples. You can do a lot of spatial transcriptomics nowadays, immunohistochemistry, multiplex immunohistochemistry. So there's a lot of potential that we're maybe missing. And really, I would not see that in any case that cytomorphology or histopathology would be replaced by molecular genetics. Definitely not in MDS. And even maybe that by using these kind of novel techniques, we maybe can understand better the morphology and kind of use that to build robust biomarkers for treatments and to guide in diagnosis. And maybe the next WHO or ICC or other myeloid classification will maybe again find new features from these morphological data that can be used to make even better classifications. So with that, I would like to thank especially researchers in my lab and the founders, and please, if you have any questions, you can ask or send me an email. Thank you.
Thank you very much, Oscar. This was a fascinating talk and great data. Questions? Yes, please, go ahead.
Thank you for your great talk. I'm Nayan from Tokyo. And you showed that computers can identify some morphological features that is specific to some genetic abnormalities. And my question is it possible to translate these features into a language that can be interpreted by a human being?
Yes. So if I understand correctly, the features that the machines are kind of learning, so they're not really, we're not specifically teaching these for the molecular genetics. It's just to show that we can show the link between the genetics and the morphology. And yes, that's the second part is obviously the kind of the most interesting part. So can we kind of have the human there to interpret again that what these are seeing, that yes, these are correct or not? And probably there will be many kind of but Professor Bennett showed this, that there's a lot of kind of very specific groups for dysplasia that we can now classify. But probably there will be much more subtle changes that are difficult for the human to say accurately that this is not maybe dysplastic but altered, and maybe the machines could help there. And maybe we can that way better understand the kind of a spectra of the morphology.
Thank you.
Maybe I have a question. So you have now all these algorithms, but who is the ground truth in your lab? How many people are saying this is a blast and this is no blast, and they kill each other if they are right or wrong? How many people are the ground truth?
Well, we had in total, we have maybe 4 or 5 different people annotating these, and it's been a mess, to be honest. So
it's a challenge.
I kicked out 3 of them because no, it's yeah. So it's very challenging, and it's also that we need to really agree on what is what, and yeah, and had the laboratory physicians also on board that they can that we all agree together.
And you improve during time while discussing things like that.
Yeah. So that's interesting as well. So annotating images, even by somebody that is an expert in the field, it's a very challenging task to annotate this, because the physician can be very strict or very liberal in annotation process. So we have to have really strict rules for the annotation.
Thank you.
Yeah.
Yes, please, go ahead.
Good morning. I'm Thirin from Thailand. I would like to ask you some questions. And do you think the model that developed in different countries can apply into another country? Like, for example, in Thailand, we have a half of population have a thalassemia trait that very maybe low MCV. So the lower of MCV, this feature cannot predict something like that.
Yeah.
Very good question.
Yeah, so that's the most difficult part of the whole thing. So, so I mentioned that we had 10 different centers, samples from 10 different centers, and that's the most difficult part, to show that the models actually work for each of the centers. And to that, there is no easy solution. We discussed just before the presentation that it would be really nice to have like this kind of a more open collaboration on sharing images, and to make sure that if you build a model, you can use that in Thailand or in Japan or in Europe, and you can make sure that it works. Now at the moment we can see that it works as long as we don't have a new center. And then we have a new center, it's always a bit stressful, does it work or not? Sometimes it does, sometimes it doesn't. So it's very sensitive to that.
Thank you.
It's actually last question.
Okay, so only God knows the ground truth. And so any teacher have some mistakes. And then those mistakes, to what extent those mistakes influence the development of the such system? And my interest is, so when we use a lot of samples, such as small mistake could not be not relevant. And I mean, there is some, and so there are some singularity point could be expected to join such systems.
There's mistakes in annotation, and it doesn't matter as long as it's systematic. So it's if you have 100 samples or 100 cells and 95 of them are annotated correctly, it doesn't matter if the 5s are wrong. The model understands the idea. It may be the confusion matrix doesn't look that nice, but when you run the model on a new sample, you can see that it works still quite okay. And it's not realistic to have 100% accuracy. I think that if you get 90% or more, it's perfect already.
Okay, thank you.
Thank you very much, and thank you, great talk.
Next speaker is Dr. Torsten Haferlach from Germany. And the title of his talk today is Use AI for Diagnostics, etc. Thank you. So please, Torsten.
Yeah, good morning, everyone. Thank you very much. And it's actually, thank you very much for the invitation. It's always an honor to be here and to be with you. So I try to make a broader view, and this is my disclosure. I am the part owner of the Munich Leukemia Laboratory. And during the last day and the day also today, we already heard and know that there's a broad spectrum of diagnostic methods to be applied to the diagnosis in MDS according to WHO ICC. And thinking backwards, what do we need to serve our patients best? Set that as the most important goal. You know all these different things here on my list. I will not read it to you, but you know this, you heard this, and we apply this on a daily routine. And all methods, now color-coded in red, and readouts are based on phenotypical features and low numbers of events. Low numbers is 100 or 200 or maybe 500, but from the biostatistical point of view, we speak about thousands, hundreds of thousands and millions. And this is a very old paper published by an informatician. How many cells should we count? I always like all these discussions with people talking about 5%, 10%, 20%, and they discuss it hours and hours, although they never read any bone marrow a day. So this is, for me, quite difficult to understand, especially when you see this here. This is from the table. So 95% confident that something is there that is there. Let's see if we have 10 and you count 100 events. The range is between 4 and 18. If you go for 200, it's between 6 and 16. Even if you would count 1,000 cells, and 10 are the one you really want to count, the range is between 8 and 13. This is just to let us know that even from the biostatistical point of view, you cannot rely on what your number tells you. And this is even more critical if you go for the phenotype. And I know John Bennett, and I like him so much since more than 30 years. We worked together since 1992. And you heard about this, with all these definitions this morning, and all these features. And I'm sure they are of importance. We apply them every day, and we will apply them also in the future. And he didn't show you this paper. This paper is now 42 years old. And there, they defined for the first time how to diagnose from the morphological point of view. There were very few data on cytogenetics. There were no data on molecular genetics. There were no data on flow. From the morphological point of view, MDS. But there is only one John Bennett and Peter Greenberg and me. And therefore, when this knowledge is gone someday, this is gone. And everyone who has to train phenotypical knowledge has to train that. And this is a recent study from MDS, and they looked into the reproducibility of the diagnosis. 918 cases diagnosed by the local center as an MDS. And then they gave it to 3 independent pathologists and let them look into this. 1/3 of cases reclassified after central review, half of the discordant diagnosis due to coding errors, but in 7% of misdiagnosed cases, those patients receive inappropriate therapy. This is the truth in 2023, based on morphology. So if we have this now as our ground truth, then we can go forward with what can we learn by applying AI, not for us, not for our being important, but for patients' care. This is cytogenetics. I will come to this back later. And this is, as you all know, molecular genetics. There is more or less, as we all believe, a very reliable method to come to a conclusion. And we use all these genes now, including these copy number variation panels, because, Elsa, you were there, we need this biallelic knowledge of TP53, for example. We need this combination of different methods. And the question is, having said that all, what do we need from now, and could we use some approaches of AI to do that? So first of all, how to confuse a phenotype-driven machine learning model. Look here. Or here. Or here. I think the last one is quite easy, but it's not so easy that you couldn't be confused. And therefore, start with a peripheral blood smear. We just heard from Oscar that you can do this. We do this as well in our daily routine now, and we worked on that a long time. And this is the smear. So we have the automatically stained and then microscopic pictures of the smear. And from the human control, for the human control, you first of all see this, the smear, and then you see this magnification, and you see this magnification. So you first of all have the option to control how the smear is, how the staining is, or the blood looks like, the white blood cells, the platelet count is. And then, in parallel, you don't need to look into this, but then the microscope takes these pictures, and one cell is in the middle of each picture with 100x magnification without oil, and then the microscope automatically puts oil to the smear and then takes these pictures. And from these pictures, they go to the AI algorithm, and then you have a table with images, a gallery, and you can say, well, you say these are all the polymorphonucleus, I agree with you. These are all the eosinophils, I agree. If you don't agree, you do a drag and drop, then put them in the new box. So we did nearly 3 million cells differentiated by us as humans, and 500 cells per smear, 5 times as much taken pictures. And this is the overall differential from humans and from the AI. And although this is not 100%, and we are sometimes not so close away, but sometimes far away from 100%, we can say that the concordance is 94.5%, especially for the malignant, the critical cells, the blasts, the hairy cells, the plasma cells on the peripheral blood, those that you should pick up, at least those. I don't care if there are 2 or 3% more polymorphular nuclear cells or not. That doesn't mean anything. Oscar, you just said it. Now, what we did right now is we improved our algorithm in daily routine, and the accuracy to count the cells correctly is now 87% in the last month, and half of our cases, here is 800, go for AI first and then to humans, and the other half, mostly those who also have bone marrow in parallel, because this algorithm is now just working on peripheral blood, go to humans only. But anyhow, half of our cases go to machine first, AI first, and then by control of humans, and then the report. It looks like that. The scanning, 10x and 40x, so 100 and 400x. Upload the images to the cloud. Routine working in the cloud, class prediction in the cloud. You see it's only seconds over there. And then the result visualization, bringing back to you in the gallery, control in home office or in the laboratory, and then writing the reports. And this is the workflow we use right now for all the peripheral blood. That is only peripheral blood in our daily routine. It's between 50 and 150 cases per day going to this workflow every day. There's a very recently published paper from this group, and they used also a completely automated microscope from Cellavision and Sysmex to pick up MDS, CMML, or none of these, and they looked into more than 700 cases, and also in parallel a routine cohort of 37,000 cases into these entities here, and they found a concordance of 92% between human and machine scores with respect to dysplasia and the cell types. CMML score was very high with respect to sensitivity and specificity, MDS a little lower. You heard John Bennett, and you may understand why this is correct like that. And the final flow chart says that the AI should be assist cytologist and smear review, and they, with this combination, first the AI, then the humans, they reach a very high sensitivity of 0.9 and specificity of 0.9 as well for detecting MDS in an unknown cohort of patients. So we are going to this way step by step with all these different methods and microscopes, and we are now working on the bone marrow to do this. You take one picture, the AI separates the respective cells on this picture. So one picture, 150 different cell images, and then you move over by separation of the respective cells, and then you go for the differential counts, and we are just working on that, and hopefully we'll have this ready for our routine use in parallel to our human controls in the next 6 months. Now, flow is another method. We developed our algorithms with many, many cases, but this is only 10% of cases we have. They are all digital. All data is available of AML, MDS, ALL, non-Hodgkin's lymphoma, multiple myeloma, and NHL, and the MDS cases are 5,000, yes, MDS proven by morphology, cytogenetics, and molecular genetics, and by flow, and 6,000 as a negative control. How do this algorithm work? It does not work on that what we are used to use. These are these patterns of scatter diagrams for the flow as humans use it. But the algorithm only takes the raw data. Percentage of CD3 expression, percentage of CD13 expression, percentage of. The raw data as a matrix goes to the cloud, goes to the algorithm, and comes back with pictures like that, and demonstrates here the pathogenic cell population. And for your human control, they recalculate scatter diagrams like that. So you can control the algorithm backwards, and then the algorithm comes with a probability. It's an explainable AI. It's not a black box. So here, the algorithm said there is no evidence of MDS in this case with a probability of 99.36%. No evidence of MDS. And therefore, we just, first of all, have the raw data, go to the cloud, get back the information, get back your pictures for your control, and also get back a number with a probability that this is something and this is nothing. Now, very few people of you are used to read chromosomes. I cannot do this. I'm married to a cytogeneticist. That's the easiest way to learn it. And therefore, I don't know how that works. So this is the metaphase. This is taken automatically by a microscope. And this is now a real-time video from one of our very experienced technicians. It starts here. What she's doing is she's taking this metaphase and putting it to a karyogram. You know you need 20 karyograms to write a report according to ICN. For chromosomes, she has to cut all these chromosomes where the machine wasn't sure it is 1 or 2 chromosomes, so she's doing it right here with a mouse click. Then the algorithm that we used until 2019 puts the chromosomes according to their respective size, and then by mouse click and knowledge, phenotypical knowledge, experience, she clicks these chromosomes to the right position in the karyogram. This is what we did over decades and decades using such a system. Right now we have to wait. Oh, it looks like this man or woman, we don't know so far, will have a trisomy 8. And we have to wait that this is done. And I can tell you, she's really very experienced, very quick. And this is real time. And finally, we are done here. After 42 seconds, I spoke to you, and now we know it's a man, XY, and a trisomy 8. Now, we take the same metaphase, and now and this is routine in our lab since 2019, we use AI to do the same. And I tell you when the human starts to work. This is now, from here, it's AI. No human, it's only AI, it's still AI, and the most important step is here, and then the human starts. This is the human control. So all over, including the human control, it's 12 seconds. From 42 to 12 seconds for one karyogram. Now what we do right now is when these pictures are taken from the automatic microscopes in the middle of the night, 7 days a week, 24 hours a day. And I upload here for you 20 metaphases, and this is the real-time speed now from a metaphase to a karyogram. One machine can do 8,000 metaphases per hour to a karyogram for finally human control. This is a huge step forward, and I can tell you that we have to completely reorganize our education of the new technicians, because you're not allowed to reorganize any AI-given karyogram before you are 2 years in the lab, because the first 2 years the AI is even better all the time. And I can show you here what we did. Since 2019, we have these algorithms in our routine. More than 100,000 cases went this way. First AI, then human control. More than 2 million metaphases means more than 92 million chromosomes. 92 million chromosomes. So normally the karyograms for not experienced like our technicians are takes 2 to 3 minutes. Now the network from the AI takes 5 seconds and then 30 seconds for cytogenetics for control. And that reduced the working time a lot, and also the turnaround time. This is manual before, this is AI now. Many more cases, 3 days before the result goes out, more 4 days, and less cases with 7 or more than 7 days turnaround time before the result goes out. This is completely a revolution in this very important method to send out the reports. Here's the last year only, 5,300 cases, MDS, yes or no, all with chromosomes. Here is the final diagnosis from morphology, flow, and molecular. MDS, yes. MDS possible, morphology not quite clear, and MDS not confirmed. You see here normal karyotype trisomies and monosomy 7. This number, normal, especially normal, 58, 80, 88% goes up. And the aberrant karyotype goes down based on what morphology said. And this is all the cytogenetic results. And we now combine 3 neural networks to do this. We just trained, this is data from this week, the normal prediction that the normal is normal on the rank 1 of the calling is 99.1% and rank 2, 0.9%. We can pick up the derivative 1,7 in 99.4 and rank 1, 922, 99.2, 1114, 100%, 1517, 95 first rank, 4.9, 100% together second rank. And the next step will include all this, and we train this as well. We have hundreds of thousands of cases, we can do this, and we will also pick up them in the 99 range before the human should control. Finally, they will not control anymore because they will lose the knowledge to control that. This is a completely disruptive innovation in reading chromosomes. Now here we go for molecular genetics. We have to do this. This is all standard for variant discovery and variant interpretation. And we also use a predictor that tells us how sure we are. With one step in the cloud with the information from Cosmic ClinVar, and we have our own MLL predictor that tells us how sure we are, how often did we see this specific mutation, and what was the knowledge that we implemented before to rate it as a variant, a mutation, a variant of insignificant or a benign change. And the question is right now, are we staying with the panels of what we are doing right now, and this is gold standard and routine for sure, or are we going forward? These are more than 4,000 cases. We now have 6,000 genomes and transcriptomes from all our data. And here's the gold standard. Here's the ground truth. This is what we diagnosed those cases. And this is what the AI told us based on the genome and the transcriptome. Right now, the accuracy to predict the right diagnosis based on AI only and the genome and the transcriptome is 88%, not 100%. But where are the wrong cases? This is AML and MDS. You know, 20% of blast. This is the threshold. So AML and MDS by humans, me and my colleagues, and here the AI. And you see here are the MDS and the AML cases. And the discordant cases is 4.3%. So that's okay, that's not so bad. Maybe the genome and the transcriptome is even more correct than what we counted when we made it in MDS or AML just based on the blast count. And we have explainable AI. This is all cases with 5q minus MDS and low blast. So 103 cases going for the genome and the transcriptome in our database, all with the same diagnosis. The new case is coming in here in pink, and all these samples are the training samples, not 5q and not the new case. And you can see why the AI algorithm finally came to the diagnosis of an isolated 5q MDS. It puts them here into the complete cloud of all the other cases, and then it gives you already the karyotype based on the DNA with the 5q deletion and a TET2 and a DNMT3A mutation in addition, and then it gives you the probability, MDS with a probability of 95.5%, second AML, third MDS, MPN, U. Now, what about this? MDS, MPN, RS, or SF3B1T. This is a quite difficult definition of something, and this disease should be in between of everything. So what will AI tell us about this diagnosis? 109 cases in the training set, all diagnosed by us, and this was the final diagnosis. And the new case here in blue. Okay, so here is the case within all the other cases of MDS, MPN, and overlaps, and so on. This is finally the karyotype with SF3B1 mutation, JAK2 mutation, and some gains and losses as shown here in the circus plot. But what about the probability to tell us what the diagnosis is? Here we are, and this is what they say. This is an MDS, MPN, RST with a probability of 32.86%, but the second best choice would be MDS, normal, MPN, or MDS, MPNU. And that's correct, because we have the same problem to diagnose this case. We just set our marshals, our thresholds, and made the diagnosis. And the same is true by AI. The AI couldn't be better than we are. Now, large language models. Since ChatGPT, you can also include this, not only in your private life and ask, what should I visit when I come to Kyoto, but you can use it for your writing a report in your data set. Now, we used, from our 1.1 million cases, reports from morphology. 460,000 cases, here's the question of the doctor at the beginning, here's the final result at the end, and there are all the methods in between that have been taken into account to write the final report. So we put this all into vectors. The calculation time in the cloud was 3 hours. We have to investigate 3,000 euro, and then it's done. And you have all these historical cases right here. You have your new case over here, and you put your new case and your historical cases in this large language model, put some instructions in, and ask the model to write the report. What would be the final report written for this case and all this information from morphology, cytogenetics, whatever needs to be done to answer the question of the doctor before. Now, we right now achieve a correct written report when we have a human control in 86%. What you have to know is if you use such language models, they have different temperatures. Temperature means, have you hallucination in the answer or not? If you put temperature 0.0, you tell the model, please be as correct, as strict as you can. If you put temperature 1.0, you say, have a good idea, think something that I never think before, be hallucinating, and give me then your final answer. So we put here 0.0. Here are two reports written for a 5q minus syndrome. You can read them, you shouldn't read them, but what you see is they are more or less both correct, they are more or less okay, and the question is who was the author, and the upper was written by the AI, and the lower was written by human. And therefore, we are okay when we are healthy, we don't have any problem with our girlfriend, we are not tired. We can do this, but the AI is never tired. I did this yesterday here when I was listening to the other talks. I have a patient diagnosed with MDS with blast below 5, 45% of ring sideroblast, SS3B1, white blood cells and platelets normal, but hemoglobin is 8. What should I investigate more, and what treatment is best to use? JetGPT 4.0 yesterday. Well, comprehensive cytogenetic molecular testing, although as it is noted, which is in good favor for roses, a comprehensive panel should be considered to identify and additional mutations and abnormalities should be influence treatment choices. Then evaluate iron storage and iron overload, full blood count for follow-up studies, hemoglobin stem cell transplant should also be considered and at least thinking about. And treatment could be erythropoiesis stimulating, luspatercept, particularly effective in patients with SS3B1, iron chelation therapy, and so on and so on. All within 5 seconds. You know all this. You are very, very famous. You know all these answers, but not anyone knows it within 5 seconds. Next question. Oh, I forgot that. What is the dosing of luspatercept per day? Oh, and here's the answer after 2 seconds. You can read it, it's correct. You can do it like that. You know all that, but someday there will be something you don't know. So you may think about that. We used this together with Aziz Nazar and Michael Sakaris some years ago and published this in the JCO. And these are a huge number of cases with MDS, very long follow-up time, more than 15 years. You see, wild type is mostly always better than mutation, but one exception, the SS3B1 is shown here. And you can see here by IPSSR, it was before M, the category with very low, low, intermediate, high, and very high, and this was the survival time. All these patients died, so we know that this was their survival time. And the algorithm used by AI, the unchanged are the orange cases. So these orange cases with a very short survival time were more or less here, but there were also unchanged cases over here with the longer survival times. But there were upstage and downstage cases by the AI algorithm. So it was an additional information that had been not before when we used the IPSSR. Finally, this is a talk on MDS. It was given by one of my colleagues in my lab for our new employees. It is consisting of 57 slides. I will not give you to this talk, but if you want a conclusion, if you want just a summary of this talk, you had to listen to this talk. It's in a video, like John Bennett has a video. So we can use this talk. The talk took 32 minutes. We have this audio. We put it into a speech-to-text model. So the AI just listens to the talk. But how long does it listen? 1 minute and 54 seconds. So nearly less than 2 minutes. Then we have the transcript. 5,000 words, 5 pages. Then we take this transcript for 35 seconds, and then we have the summary. All over 2.5 minutes. Maybe you just want a summary of a paper. You just want a summary of the talk. If you're a human, you need to listen to that. You make your summary, and you take 45 minutes. Okay, this is all AI, but we are human. We are so good to speaking to our patients. We are so empathic. Is this really correct from the point of view in these days of AI? This was a paper published last year, and this was done 3 weeks after JetGPT came to the world. It was done in December 22. So this is an American homepage where you can ask something, and there's a doctor on the other end of this homepage and gives you the answer. I feel this and this, I am afraid I have this and this, and the doctor gives the answer. 195 exchanges verified by physicians, and the question was, how correct is the answer? And we have 5 different reviewers: the question of the patient, the answer of the doctor, and 5 different reviewers. Well, the quality of the answers says, well, the reviewers say, well, the physicians are acceptable, but the chatbot answers are better. But what about the empathic responses? Here's the answer. Physicians, chatbot. This was blinded. So we are sometimes not very polite. We don't have time to answer our patients. So we have to think about this as well. What I think is, for the future, the vision at least, and we built this up in our lab for diagnostics. We start with the question of the doctor. He's writing something on a paper I cannot read, but the AI can read it now. We have an order control that decides what methods are the best methods to diagnose. For CLL is quite different in comparison to MDS. Then we have all the lab working. We have the people, the hematologists, the molecular biologists that write the reports. They write the reports. Then we include AI and automatically implement in the report writing the complete new WHO, very big paperwork. PubMed, up-to-date, NCCN, clinicaltrials.gov, our German guidelines, and then send out the report to the doctors at the end. And all these steps are supported before humans do it by AI. And this is what we can do right now and what we can apply right now and add it to our daily routine. So thank you very much for your attention, and thank you for my dedicated team of the MLL. Thank you for being and listening to me.
So thank you very much, Torsten, for your beautiful talk. I very much enjoyed it. So any question or comment? So please use the microphone.
Wow. Torsten, it was fantastic. I knew it was going to be good, but it was fantastic. I have many comments, but I'll be short. Number one, you know, when I'm thinking about that, I remember the famous musical from 1946, anything you can do, I can do better. So probably that's what the computer thinks for all of us. Anything that we can do, the computer can do better. Usually, I am not in favor of revolution. I am for evolution, but I think we are in the middle of revolution, and I think you are one of the pioneers of this revolution, because I think that in 10, 15 years from now, the young people who will be then seniors will say that in these years, this was the change. I'm not saying that morphology is not right ever. Morphology is still important, and John Bennett would agree with me, but I think we learn how to transform, you know, what we can do to a better way. Yes, and question, there is one thing that John did not talk about it, you did not talk about it, because in my understanding, everything that we see in morphology, we can see by the computer systems, by the digital system better. There is one thing that you didn't mention, and this is cellularity. We always look at the bone marrow, and we estimate the cellularity, and every report starts with hypercellular, hypercellular.
Excuse me.
Unfortunately, this has not been translated
question,
practically.
It will be.
What do you think?
It will be translated, and we take the complete bone marrow smear picture and then move forward. And with the other aspect, well, it is our duty now to control these algorithms. We have to do that because we are still there. In 5 to 10 years from now, people will say to us, this is now the algorithm, I don't know if it's correct or not, but you had to control this 10 years ago. Now, it's our duty to do this now.
So ELSA developed the IPSM for taking 5 years or something. So if you have the 5,000 MS patient all data, so can I ask ChatGPT to create a better prognosis model than IPSM? Is it possible?
Yeah, we have these algorithms in-house now. We have ChatGPT in-house, not outside. So our data stay in our in-house control, including ChatGPT and other AI machines. And we took 5 days to build a new algorithm that's not quite far away from your algorithm. and the number of what you are giving is on the highest rate that our algorithm uses. So it's within the data from our lab, not your data. The data from our lab can do it within 5 days using algorithms like that.
So another shot. When I visited your lab in 2013, I see a lot of people in front of the monitor and doing the karyotyping.
Yeah.
So did you fire many of them?
No.
Okay.
Zero.
Zero.
Zero, because we have more and more work.
So
we have better work for them as well, because they are very experienced, very dedicated people.
Okay. Okay.
Zero. They are lucky that they have it. If they wouldn't have algorithms like that, they would not come to us.
Short
Thank you,
question,
Torsten. Fantastic talk. I have perhaps a different question. It has been known from AI, ChatGPT and others, when you let it go for a while, that there is a tendency for a more authoritative, it goes towards an authoritative aspect of the patient, and perhaps the moral gets a bit declining over
Yes.
time. This has been fairly well described. And how do you, I'm thinking about your AI empathetic things. How do you keep track of your AI system so that it maintains ethical values?
Right now we use our AI systems in-house only for the lab and the result.
I
And
know.
therefore there is not so much ethics, just data. But in the future we have to control this as well. And there are much more applications I didn't show to you that you can use also from the AI system to order the CT scan from when you speak to the patient, say we need to make a CT scan. In parallel, the AI already organizes the CT date to make this for the patient. So there is much more, but empathetic aspects have to be controlled in the future. Sure.
The last question, please.
Excellent. Excellent talk, Torsten. You mentioned that you could predict the diagnosis with 86% probability of the genetic data. Have you already tried to combine the different modalities, and how good can you get after that?
Yes, this is very important because we have the option to combine this, and if you combine morphology and flow for the diagnosis of CLL, you are 100% or 99.99, and this is true also for MPN question mark, morphology, cellularity plus JAK2, yes or no. You are higher than before, and as we have all this information in-house here, in our laboratory, we are now combining these algorithms due to the workflow, and then we have finally an integrated report that is sent out by combining all this by AI tools. Correct.
So thank you very much for your fascinating talk and active discussion. We close this session. Interesting.